So we talked last time about the ways in which bacteria can develop resistance to a wide variety of antibiotics and other drugs as well. Do bacteria just evolve resistance to antibiotics? No, you can resolve resistance to antivirals as well. That's why long-term AIDS therapy, you have to keep coming up with some new drugs or new combination of drugs, because virus evolved resistance as well as bacteria evolved resistance. The mechanisms are quite varied, but the initiating event virtually all the time is a mutation in one or more genes. But once a particular species has evolved some means of resistance, whether it be a drug pump or whether it be a change in a membrane receptor or a change in a ribosomal RNA protein, once you've developed that mutation, and particularly if the gene is encoded on a plasmid, the ability to spread that resistance to other bacteria and other quote-unquote species, even bacteria that are as different as being 1 gram negative and 1 gram positive, happens pretty readily. And if you couple that with the short generation time that bacteria have, these resistance can evolve scarily rapidly. Okay? So, we talked about ways in which we can minimize antibiotic resistance, or at least introduce that topic. And basically, there are several strategies that can be employed. And one of the first strategies that really should be done, and isn't being done enough, is identifying your pathogen. So, you're a physician. Made it through medical school, made it through your residency, you're now practicing. Maybe you're a pediatrician. Parent comes in, kid's been up all night. I think they have strep. Okay. You're trying to run patients through. Do you know what kind of average for doctor turnover for patients is, where they kind of schedule and program? About once every 20 minutes. Okay? And that doesn't account for emergencies. So if you have an emergency, then some of those get pushed shorter, people wait longer. So you're really under the gun in terms of time and not spending too much time with patients. So you've got a pretty insistent parent, and they say, give me some antibiotic. Okay? Probably statistically speaking, the chances that the child has strep are less than 50%. Very oftentimes for both strep and ear infections. And those are two infections that really cause kids discomfort. And if they're up all night crying, they're miserable, you're miserable, so you want some resolution and some solution. So the fastest, easiest way to do it is to prescribe the antibiotic, even though 50-50 chance it won't do anything. We should be identifying the pathogen, but that typically involves taking cultures, or if you're lucky, there is some kind of a rapid antibody test that can detect the presence of the pathogen without doing a culture. But are you out of the woods yet in terms of being a good physician and trying to do things that would minimize development of antibiotic resistance? Okay, what if it comes up positive and it says this is strep? What's something else you should do as a good physician, a follow-up step you should do to be responsible? You know it's strep. So you remember from all of your residency training, well, what's the drug you typically prescribe for strep? Well, the penicillins. Okay, works very well. But what's the possibility with prescribing one of the penicillins? Bacteria is resistant to it. Okay? So really, one of the things that's done even less often, unless you're in the hospital, is that some type of a susceptibility test is done on the bacteria. And you actually test the pathogen that the person is harboring to see if that particular strain is resistant. Because if it is, and you provide methicillin, for example, and the bacteria is resistant to it, it does no good. And that's really as bad in terms of encouraging resistance as prescribing an antibiotic for a viral infection. Okay, it's not going to help the patient, it's not going to kill the bacteria, but it might affect other bacteria. Okay? Those antibiotics, when they're prescribed and they're used, particularly in the hospital, can get aerosolized, and they can get in the air. And then other bacteria that are exposed to those will be affected, and resistant strains will be selected for. So there's some methods you can do to do susceptibility testing. And there's a simple one called the Kirby-Bauer test, which is really more of a qualitative test. Basically, it says resistant or not. But it doesn't really give you any quantitative data to speak of in terms of measuring relative resistance. Okay? Sometimes things are highly resistant, other times they're not as resistant. The Kirby-Bauer test basically involves taking an agar plate and seeding it with bacteria. So when you pour the agar plate, you put the bacteria from the throat culture in with it, mix it up, let the plate harden. So now the bacteria is distributed through the plate. If you stick that in the incubator, what's going to happen to the plate? It's going to get cloudy, right? It's like we did with the mouthwash experiment 4 years ago. Okay? But what did you do in the mouthwash experiment? We wanted to see if there were chemicals in the mouthwashes that inhibited bacterial growth, so how did you test that? Put the chemical in a filter paper disc that was sterilized, put it on the plate before you put it in the incubator, and those chemicals that were in the disc would diffuse out into the agar, and what would happen to the plate if the chemical was antibacterial? You would get that zone of inhibition, okay? And so you can do something like that, and instead you would have antibiotics impregnated into organisms, and you would look for zones of inhibition. Okay, so here's a Kirby-Bauer test that shows several different antibiotics being tested on a particular bacterium. Oxytetracycline, gentamicin, ampicillin, etc. And just by looking at the plate, which of the antibiotics would you suggest that the bacteria is most sensitive to? Yeah, the one on the top, enrofloxacin. Why? Because it has the biggest zone of inhibition. But it's not quite that simple, because the size of the zone of inhibition is dependent upon two factors, really. One is how well the antibody kills. So what's another factor that influences the size of that zone of inhibition? Diffusion rate. Okay? So something that diffused very fast might give you a big zone of inhibition. Something that diffused less slowly might give you a smaller zone, even though it is more lethal. So there typically are guidelines, and you have to measure the zones of inhibition, and then you look at a chart, and it says, if the zone of inhibition is greater than so many millimeters, then that indicates resistance. Or if it's less than so many millimeters, that indicates lack of resistance. So you can actually get a zone of inhibition, and still it's considered to be a non-resistant form. There is another test that you can do that has a quantitative aspect to it, and that is called the MIC test. MIC stands for minimum inhibitory concentration. Ideally, doctors would like to give you a dose of antibiotic that was just enough to effectively kill the pathogen and not give you an excessive dose. Why not an excessive dose? Yeah, I mean, we're going to talk about some toxicities associated with antibiotics, and usually those toxicities are dose dependent. So the greater dose, the greater chance of toxicity. Okay? So what the minimum inhibitory concentration determines is what is the lowest concentration of the antibiotic that will effectively kill the bacteria. If a very low concentration will kill it, then that implies that the bacteria has little to no resistance. If it takes a much higher concentration to kill it, that would imply a higher level of resistance. So this gives you just not a yes or no answer, but more of a quantitative type answer. This involves doing a serial dilution of the antibiotic and aliquoting the antibiotic out. Oh, there's a good kind of close-up of the Kirby-Bauer test. This shows something that I didn't mention. I'll go back for just a second. Sometimes two antibiotics working together actually give greater inhibition than each individual antibiotic would by itself. That's called synergy. So you're seeing some synergy right here, and the zone of inhibition is actually greater in here than it would be for each individual antibiotic. Okay, this one's a little bit hard to see, but here is an MIC test. Here's a series of tubes that have bacteria in them, and then aliquoted into those will be serial dilutions of antibiotics. And so here will be increasing concentrations of the drug. And you can see at some point that at this particular concentration of the drug, we're still getting growth. And over here now, the tubes are clear. So the first tube that is clear gives you the minimum inhibitory concentration. This is kind of a pain. It's kind of a pain to have to do all those serial dilutions and to work with all those tubes and pipe out all the bacteria. And so somebody, pretty clever, came up with an alternative for this particular test called the E-test. And this involves these little strips right here. And these strips are impregnated with antibiotic in decreasing concentration. So up at this end, it's higher concentration. Down here, it's a lower concentration. So what they do is they do a plate like the Kirby-Bauer plate, and then just lay these little E-strips on top of the plate. And what happens? You see that the zone of inhibition starts getting narrower as the antibiotic concentration starts to decrease. And at some point, there's no further inhibition. So what does this tell you? This tells you the MIC is 1 on this particular strip. That might be 1 microgram per milliliter, for example. Okay? So this is a much faster and easier way to do the MIC. And this is something that can be done, in a doctor's office potentially. You start getting into all those serial dilutions and things, doctor's not going to do that. But potentially something like this could theoretically be done. More likely this would still be done in a hospital setting in a med tech type lab. There's another reason that it's important to do MICs. And that's so you can calculate something called the therapeutic index. Therapeutic index is the ratio between the toxic dose of the drug and its minimum inhibitory concentration. So let's say we've got 2 choices for drugs to prescribe for a particular infection. We know it's a bacterial infection, we've done susceptibility testing, and we know that we'll be susceptible to the drug. So now we want to know what the therapeutic index is. Let's say these 2 drugs had the same toxic dose. But the MIC for this one was 9 micrograms, and the MIC for this one was 1 microgram. So this one would have a therapeutic index of 1.1. This would have a therapeutic index of 10. When you're prescribing, you should always try to choose the drug that has the highest therapeutic index. The biggest disparity between the toxic dose and the effective dose. Okay? Here it's really close. Okay? You're really kind of right on the line here between toxicity and effectiveness. Here you've got some margin for error. So therapeutic index is an important concept to understand when you are prescribing. Another issue that really needs to be addressed in terms of making good choices for choosing antibiotics is avoiding broad spectrum antibiotics if possible. ideally, if physicians had a very narrow spectrum drug for every potential disease organism, that would be best. Why? That would be good to have just targeted as opposed to carpet bombs. Well, supposedly at least, these antibiotics are going to be specific for the bacteria, so we're not worried about hurting other tissue. What are we worried about?
More overall resistance.
Okay, affecting more than your target bacteria and encouraging resistance in them. And what's another factor? What's wrong with carpet bombing all of your bacteria? What does that assume? It assumes they're all bad, they're all pathogens, and we know better than that now, right? We know that there are a lot of beneficial bacteria, so the use of the broad spectrums really does have a lot of collateral damage on other bacterial species, causing greater resistance in them, even though they're not the pathogen at this particular point in time, or that they're a beneficial microorganism. Why are there so many good broad spectrum drugs out there? What's the other side of it? If you've got, if you're a major CEO of a pharmaceutical company, are you going to be encouraging your researchers to develop new broad spectrum antibiotics or selectively targeted antibiotics? Broad spectrum. Why? I mean, a greater, sales potential, greater potential use. A doctor can, only have to remember a few antibiotics as opposed to one for each one. And so there's a lot of pressure from drug companies to develop these broad spectrum antibiotics. And sometimes they're indicated. But it's not something that's given a lot of thought about trying to find a particular antibiotic that is targeting only a particular type of microorganism. We've also already talked about patients' responsibilities, and that is to take all of your antibiotics that are prescribed. Has anybody ever cut short and saved? Yes, you have. Have you taken them again later? Self-prescribed? A lot of people do. But remember that when you do that, the risk that you run is that taking them through the whole course of the antibiotic should get you down here. If you stop, you might be here. Your symptoms may have subsided because you don't have an active growing population now, they're declining. But you can get that rebound if you're not careful. And because the antibiotic is selective for killing sensitive forms, the ones that are surviving are by nature tend to be more resistant. So you also have responsibilities as a patient to do what you're supposed to do. It's not just the doctors that have the responsibilities. There's a huge issue in the antibiotic world that some countries have started to address, including the United States, many European countries, but many countries haven't. And that is the use of antibiotics in animal feed. It's estimated worldwide that about 70% of the antibiotics that are produced end up in animal feed. Zach, do you have any background on this? Can you give us a little...
I know there's a lot of antibiotics and a lot of the supplements that we use, for, especially the show cattle. It does help with the costs and stuff, like the pasture cattle get costs and stuff a lot easier once they keep up with money.
Yeah, the theory is, and there's actually some evidence to support this, is that this prophylactic, this preventative prescription of antibiotics to animals helps them to gain weight faster. And the idea is that they're a little bit healthier, that they don't succumb to infections that might normally weaken them a little bit. And there is some evidence that there is a gain in weight.
Also, it has to do with some of the rumen too. There's a lot of microbes in the rumen. And when we switch the feed base from an actual grass-fed diet to like a more of a grain-based diet, those rumen microbes aren't needed as much. So like if you it converts, like with the less population of microbes in the rumen, it converts it slower so they don't get upset. So it makes it easier.
Okay. So I mean, so there's some reasons to do this, but unfortunately now all of these antibiotics that are being used are contributing to the massive problem of antibiotic resistance. And several times we've specifically identified the origin of resistant forms of antibiotics, first in animals, and those particular bacteria can transfer over to humans, particularly their GI bacteria. One of the first vancomycin-resistant strain of bacteria was traced back, and its origin was to cattle and vancomycin in cattle feed. So that's an issue, and that's one that some countries have banned. I think Denmark particularly banned it in the 90s, and they really haven't seen any decreased yield as far as their beef industry is concerned, but they have seen a real decrease in the rate of antibiotic resistance in that particular country. But many countries, no, they're not doing it at all. Another problem is that we have to have prescription to get antibiotics, right? I mean, really, I can think of very few instances where you can get your hand on any antibiotics other than topical creams like bacitracin, which have Neosporin, which has bacitracin in it. But any of the oral medications, for example, require a prescription. Okay? That's not the case in all countries. I guess it's been about 5 or 6 years ago. I went with Dr. Poley, who probably most of you don't know now, down to Belize for a winter term class. And when we were in the airport coming back, there were these big vending machines, and they were antibiotics. Okay? They're sold over the counter routinely in drugstores, no prescription. And so any time that somebody's feeling not so good, their first thought is, well, I'll go and get an antibiotic. And so the use of antibiotics and the regulation of antibiotics in those countries really contributes tremendously to the development of resistance. I've mentioned a couple times there's an antimicrobial drug called isoniazid that is used for treating tuberculosis. In India, that is sold as a lung vitamin over the counter. And virtually all of the strains of the Mycobacterium tuberculosis in India now are resistant to this frontline drug. Same has been true for medications to treat cholera in India. And resistance to those medications for cholera have evolved very rapidly because of the widespread unregulated use of those antibiotics. Something that's happening more frequently now is doctors might prescribe 2 antibiotics simultaneously. One possibility is because of this idea of synergy, and they might reinforce one another. But the other idea is you're playing kind of an odds game. So let's just say that in a bacterial population, the rate of evolution of resistance to antibiotic is about 1 times 10 to the minus 7 cells. Okay? So in a population, about 1 out of every 10 million become resistant spontaneously. If you do 2 antibiotics and that one has the same rate of resistance, then the likelihood that they will be resistant to both is 1 times 10 to the 14th, the product of those 2 individual resistance. So by combining antibiotics, you're really increasing your odds tremendously that you're going to knock out the infection, even though it might be resistant to one of them or marginally resistant to one of those. I don't think I mentioned this. Anybody ever taken Augmentin or heard of Augmentin? What'd you take it for?
I don't remember what it was when I was little.
Yeah. Augmentin is actually a mixture of 2 drugs. It is an antibiotic. It's a mixture of amoxicillin and then a compound called clavulanic acid. Clavulanic acid is a compound that destroys beta-lactamase enzymes. Remember beta-lactamases are those enzymes that chew up penicillin? So clavulanic acid inhibits those penicillin-degrading enzymes. So by mixing amoxicillin together with clavulanic acid, the clavulanic acid augments or adds to the effectiveness of that particular antibiotic. So there's some things that can be done and that should be done to minimize resistance to antibiotics. But again, since we are a worldwide economy, since we travel worldwide, unless we come to some kind of consensus internationally, it doesn't really help if selected countries just do it and others don't. It's kind of like air pollution in that respect, okay? Air pollution knows no boundaries. You're getting to the point now where, because of the way that the world is interconnected, antibiotic use really has no boundaries. And so this is something that organizations like the World Health Organization are going to have to tackle and try to come to grips with. Final issue we need to talk a little bit about regarding antibiotics is ideally they are the magic bullet that affects only the pathogen and not the host, but invariably most antibiotics have some type of side effects. The major ones are some type of cell toxicity, allergies are another possibility, and disruption of your normal flora. And all of these can occur to varying degrees depending upon the antibiotic that you're talking about. Now, some antibiotics have just some really kind of bizarre side effects. Let's take this away for a second. On the left is the potential side effect of an antibiotic called flagyl. Some of you may have had flagyl. And not everybody responds in this way to this particular antibiotic, but it can produce this kind of frightening looking condition called black hairy tongue. And flagyl does this because in some individuals it causes a degradation of hemoglobin in epithelial cells. It gives you this particular appearance. It's really not life-threatening, but it's pretty gross, pretty disgusting looking. Anybody know what this one is? This is tetracycline deposition in teeth. And this is particularly something that young kids are prone to as their enamel is developing. And that tetracycline tends to become deposited in hard tissues. Sometimes it will give the teeth kind of a mottled appearance. Those are two of the more kind of bizarre ones. I'm sure you can Google all kinds of images for antibiotic side effects and see what some of them are. Cell toxicity. The two body organs that are most likely affected in terms of cell toxicity are the liver and the kidneys. Why the liver? Yeah, I mean, the liver really functions to detoxify a lot of the things that you ingest. And sometimes the detoxification products are toxic. Sometimes the detoxification products are also allergic. If you have a penicillin allergy, anybody have one? Pardon me? You're not actually allergic to the penicillin itself, but it's actually a metabolic byproduct of the liver breaking down the penicillin that your body's actually responding to. Why the kidneys? Why are they prone to toxicity? Yeah, the drug filtration, basically. One of the things that you can do is you can develop antibiotic stones in your kidneys. and the antibiotics can crystallize out, and block your kidneys, much in the same way that kidney stones do. The most common side effect of antibiotics is diarrhea. And there's a couple of reasons for that. One of the reasons is that some antibiotics will have somewhat of a toxic effect on epithelial mucosa cells. And as your body's epithelial mucosum starts to get disrupted, one of the things that the body does, and this is really a response to infection that we'll talk about later on, but it increases the rate of peristalsis. Why does that cause diarrhea? What's the major function of the large intestine? Water reabsorption, right? And if you start flushing things through the large intestine at a faster rate, then there's less time for water to be reabsorbed, resulting diarrhea and an accompanying dehydration. Okay. Another reason that you tend to sometimes suffer from these conditions is from disruption of your normal flora. And sometimes it gets more serious than just stomach upset or diarrhea. Sometimes if you disrupt your normal flora, you can develop a secondary infection. Such as Candida albicans. I know some of you know that in here. What is that, Corey? What kind of organism, do you know? Doesn't Morton McCombs use it? It's a yeast. Okay, I thought you did. A secondary yeast infection is not an uncommon consequence of a long-term antibiotic therapy. A urinary tract infection, for example. Why? Because your normal flora, like the lactobacillus bacteria in your GI tract, produces acid, and that acid tends to suppress the growth of the yeast. In the absence of your normal flora, the yeast now proliferates and causes its own secondary infection. This is particularly problematic if the organism that starts growing out of control is Clostridium difficile. Also goes by the term C. diff. Have you ever heard of C. diff before? This is a particularly nasty consequence of antibiotic therapy. Sometimes when people are in the hospital and are on IV antibiotics, that they develop C. diff. And C. diff is not something to be taken lightly. It causes fever, abdominal pain, massive diarrhea, and it can be lethal. There are a number of people that just harbor this particular bacteria in a benign state in their gut. I think they estimated about 10% of the people in the population have C. diff bacteria. And in the absence of the normal flora, which normally suppresses this, it takes over and can cause really serious disease. You're shaking your head, Maddie. Do you know somebody that...
My mom, she's older, so when she had my brother a couple years ago, she had pneumonia. She was at higher risk for catching infection at her age. And then because of the pneumonia, when they were treating her in the hospital, she had C. diff, and so she had quarantine.
Yeah. It's nasty because, oftentimes they have to discontinue the antibiotic they're using to treat the primary disease. And these bowel diseases are really pretty gruesome sometimes. I mean, this can cause something called ulcerative colitis, which is an inflammation of the walls of the colon that lead to ulceration of it. And in worst case scenarios, you can get perforation of the colon. And then that can lead to peritonitis, which is an infection of your abdominal cavity. So it's really something that's pretty scary. And so, got to be aware of that. Most antibiotics are selective for, the non-penicillin ones at least, are selective for 70S ribosomes. But we've talked about the fact that the mitochondria have 70S ribosomes as well. So you can get an inhibition of mitochondrial protein synthesis if you're on long-term prescriptions of antibiotics. Yeah, the 7 to 10 day prescriptions, yeah, that's not going to be a problem. And what this really tends to affect most readily are rapidly dividing cells. Why do you think rapidly dividing cells would be most affected by inhibition of mitochondrial protein synthesis? What happens to a cell when it divides? It's growing and it's got to duplicate its DNA, for example, so that when the cell divides, that the DNA is a portion of both cells. But what else all has to happen when the cytoplasm divides? We've got to replicate organelles, don't we? And inhibition of mitochondrial protein synthesis can interfere with replication of organelles like the mitochondria. Where are some of the most rapidly dividing cells in your body? Skin's pretty rapid. Pardon me?
Intestinal linings.
Intestinal linings, epithelial tissue in general is pretty rapidly dividing. Also the bone marrow. What does bone marrow produce? Blood cells, including red blood cells and white blood cells. These long-term prescriptions of antibiotics can lead to, if you're not careful, aplastic anemia, which is a dramatic drop in red blood cell count. So if you're on these antibiotic prescriptions, you'll typically have to go to the doctor's office and they'll take a little blood sample and run a hematocrit. You know what a hematocrit is? It's basically a hemoglobin level, and the hemoglobin level is proportional to your red blood cell count. So it's a quick and dirty way to basically determine red blood cell count. And aplastic anemia can be life-threatening. I mentioned the antibiotic chloramphenicol, which was really a small molecule that crossed the blood-brain barrier and was effective against things like meningitis, but it also had a lot of toxicity. It particularly is toxic to mitochondrial protein synthesis, and aplastic anemia was one of the reasons why chloramphenicol was really severely limited in its use. Good question. I usually know my derivation of terms too. Somebody want to look that up for me next time? Something without plastic. And then finally, allergy. That's something else we have to really be concerned about. And again, if you are allergic to penicillins, you will also likely be allergic to cephalosporins because both of them are beta-lactam antibiotics. And again, it's a derivative of the penicillin or cephalosporin and not the molecule itself that's causing the allergic reaction. Statistically, about 1 in 20 people have some form of penicillin allergy. It's kind of surprised that nobody in the class had one. Maybe you don't know you have it. That's true. That's true. Because allergies don't always manifest themselves at the same point in people's lives. And we'll talk, if we have time at the end of the semester, about the development of allergic reactions and what causes them. Corey, did you have
I would put aplasia. It just means the aplasia part is molding. So it's without molding. It just means that there's an effective development or congenital absence of an organ or tissue.
Congenital absence of organ or tissue without mold. Okay. Aplasia is molding. Interesting. Thank you. Okay, so the next topic that we're going to talk about, and this is on Dropbox, is titled Host Parasite. So now what we're going to do is we're going to start looking at the relationship between organisms that can cause disease, pathogens, and the host. And what we're going to concentrate first on is basically kind of the offensive capabilities of the pathogens. What makes some organisms highly pathogenic and other organisms relatively harmless? Well, what we're going to see is that different organisms have different arsenals of kind of offensive infective weapons, if you like. And so we're going to talk about the host-parasite relationship kind of from the point of view first of the parasite and what it has that can make it deadly. And then we'll end the course by fairly significantly spending a lot of time talking about the body's defense systems and talking about the host's response to a parasitic infection. And that's when we're going to get into a fairly detailed look at immunology. Although if you go to professional school and you cover immunology, you'll find that what we cover in probably the last 3 to 4 weeks of the class, they'll cover in 2 or 3 days in a medical school course. So it's not a bad idea to have heard of some of this before if you're going into further graduate study, because if you've never heard anything about immunology before, you're going to be totally lost when you start blasting through it at warp speed. Okay? So this material is something that, again, I really think you need to keep up with. And so I really would encourage you to have PowerPoint slides that you take notes on, use those for studying and answering your study guide questions and reviewing those. Really, the next exam will cover the chemotherapeutic agents. It will cover the host-parasite relationship. And depending upon how far we get, it might get into even the first level of defense of the human body. So just be aware of the fact that try to keep up. Okay? So we will start on host parasite tomorrow.